So you start by assessing the airways, make sure the patient's speaking back to you in full sentences. Then you want to assess the breathing. Because this patient is tachypneic and is also hemodynamically unstable, as his heart rate is 120 and his blood pressure is sort of falling towards the lower end of normal, you want to administer oxygen. So administer maximum oxygen, which is 15 litres, 100% oxygen through a non-rebreathe mask. This is important because with hemodynamic compromise, the patient is going to be slightly hypoperfused, so not enough oxygen going to the important organs, and therefore it's important to give them as much oxygen as you can. Do a full respiratory examination and order an erect chest x-ray. This is important because this patient has presented with what could sound like upper GI bleeding, and you want to make sure that there isn't a perforation involved in this. Then, because he's unstable, you want to perform an ABG. Next, you move on to your circulation. So quickly ensure you have IV access. So this will be through 2 large bore cannula. So these are usually grey in the UK, or 16 gauge. So try and place 1 in each antecubital fossa. When you've placed your cannulas, get some bloods. So get your standard full blood count, use needs, your LFTs. Make sure you get a clotting and a cross match, which is important for urgent cross matching of his blood type. If it's a woman of childbearing age, get a pregnancy test, so beta HCG, and make sure you get a lactate, which you'll also get on your ABG. Now, this patient is hemodynamically unstable because he's tachycardic, and he has given you a vague history of some sort of upper GI bleeding with the vomiting of this coffee ground material. So you want to resuscitate him with fluids. So prior to this, you want to make sure that he doesn't have any history of severe cardiac disease or renal disease. But your standard resuscitation will be 500 millilitres of 0.9% normal saline. Then you move on to do a full cardiovascular examination, and please ask for an ECG as this patient's tachycardic. You want to make sure that you measure his fluid output strictly. And for this, especially in an elderly man, it might be useful to insert a catheter. Now, this patient, as mentioned, has said that he has vomited some coffee ground material, and it is likely that this is an upper GI bleed. He's hemodynamically unstable, and at this point, you want to assess whether you need to activate the major hemorrhage protocol. So the major hemorrhage protocol is established in every UK hospital. It is a pathway that allows you easy access to blood products and also senior support. Usually at UK hospitals, it's the standard 2222 number you call, and you state major hemorrhage and you give your location. So major blood loss may manifest as hemodynamic instability, which is a pulse over 110, rest rate over 30, which means the patient is probably hypoperfused, so they have a lack of oxygen going to their organs. Their systolic blood pressure might be low, and if they have a low urine output, that could also indicate a major blood loss. It's really important that you call for senior support at this point. So what you receive when you trigger the major hemorrhage protocol is immediate 4O negative or positive in men, red blood cells, and 4 units of FFP. So you want to go on to continue your ABCDE assessment. So make sure you assess his disability status, is his GCS 15, get his BMs and check his pupils. And then look for any other causes of bleeding or any other reasons for why he is hemodynamically unstable, because it might not be an upper GI bleed. Every time you perform an intervention, so every time you give fluids, you want to go back to the start and reassess your ABCDE. So you've successfully resuscitated him with 2 boluses of normal saline, and the red blood cells came very quickly, and he was transfused 3 whole units of red blood cells. After this, his blood pressure stabilized and his heart rate decreased to 88. So you successfully resuscitated this man. Your formal bloods come back, which shows a hemoglobin of 5.4. Bear in mind that these were taken before you transfused your bloods. And it also showed a macrocytosis with predominantly reticulocytes. It also showed a high urea of 17.4 with a normal creatinine. So you're happy that his renal function is preserved. His urea is probably high due to an upper GI bleed, and this is because blood in the stomach is metabolized into urea, and this causes an acute increase in urea. So that's an indication towards this being an upper GI bleed. His liver function tests are normal, including GGT. And this is also important to look for the causes of his upper GI bleed, which might be liver. His clotting was normal, and his ECG just showed a sinus tachycardia, and an erect chest X-ray showed no signs of fluid overload or perforation. So now that he's hemodynamically stable, you can start doing a bit more of a historical assessment. The first thing you should ask is the classic surgical history, which the mnemonic is ample. Allergies, medications, past medical and surgical history, last meal, and events leading to his admission. So this is a really easy rule of thumb for a surgical assessment in an acute setting, and it gets you all the important information for preparing a patient for theatre. If you're happy that this patient is stable, you can go on and take more of an in-depth history. So this patient presented with what we think is an upper GI bleed. The important thing is to go a bit more into detail on the description of the vomiting. So was it fresh blood? Was he vomiting prior to bleeding? He describes it as coffee ground, and you need a bit more of an explanation here. What colour was it and what volume was it? And it can be really difficult to quantify the amount of blood loss in an upper GI bleed, but it's important to try. Now, vomiting prior to upper GI bleeding is important to establish, as if they have been retching for other reasons or vomiting profusely and then consequently having a bout of hematemesis, this might mean that they have a tear in their gastric lining, also called a Mallory-Weiss tear. Then you want to ask about melena. A lot of people aren't really familiar with what melena is, so it's important to describe that this is black, tarry, often foul-smelling stools. It feel quite sticky. And how long has this been going on for? And have they had any prior episodes of either hematemesis or melena? Then you want to take a full pain history, which includes Socrates. So establish whether they've had any epigastric pain or any liver pain in particular, whether this pain is associated with eating or whether it's relieved by, for example, antacids. Then you want to establish whether it's radiating. Is it radiating to the back, for example, indicating maybe an aortic dissection or pancreatitis? And what time of day? Is the pain waking them up at night, which is quite a sinister type of pain? And how long has it been going on for? You want to establish whether they've had any previous heartburn or dyspepsia. So again, this can be quite difficult to explain, but it's really important to get a history of heartburn. So have they noticed any pain in their chest that they think is related to eating? Have they had any reflux? Have they noticed any sort of acid in the back of their throat? Then ask them about systemic features. Have they noticed any weight loss, night sweats? How long has this been going on for? And then finally ask them about dysphagia. Have they noticed a difficulty swallowing over a prolonged amount of time, and is it getting worse? And you want to ask about their past medical history. So have they got a history of gastric or duodenal ulcerization? Have they got a history of gastritis or any other sort of dyspepsia symptoms? Do they have a past history of liver disease or malignancy, and in particular gastric malignancy? Have they had any prior abdominal surgery, and do they have any renal or cardiovascular disease, which is important to prepare the patient for theatre. If you know they have renal or cardiovascular disease, this will change the management options you have. Ask them about medication. So are they taking any pain relief, and in particular ibuprofen and naproxen or any other type of non-steroidal anti-inflammatory drugs? Are they taking aspirin, which is a very common medication for elderly patients to take? These both increase your risk of peptic ulcerization, as does steroids. Ask them about anticoagulation, as the patient is likely having a bleed, it's important to know whether they're anticoagulated and what this is for, as it's not always indicated to stop anticoagulation. It depends on the indication for it and the amount the patient's bleeding. Ask them about bisphosphonates. So bisphosphonates increase the risk of esophageal strictures and esophagitis. Ask them whether they've taken anything for any abdominal pain or gastritis, for example, Gaviscon, antacids, or PPIs like lansoprazole or omeprazole. And as this patient is hemodynamically unstable, you want to establish whether they're on any antihypertensive that you might want to hold for the time being until the patient is well enough to take them. Ask them about their alcohol intakes. This is really important because it's a huge risk factor for both gastric ulceration and liver disease. So ask them how much they drink a week, what they drink, how long they've been drinking for, and whether they've had any previous history of high alcohol consumption. You can also ask them about smoking, as both alcohol and smoking combined highly increase the risk of esophagitis, gastritis, and malignancy. And then you want to establish their performance status. So you can use the WHO performance status measure. You ask them whether they are independent at home, how far they're able to walk without needing a rest, and whether they've had any sort of previous large operations that have made them unfit. So our patient says that he's been passing black tarry stools for 5 days. He's had long-standing indigestion, which has been managed quite successfully with Gaviscon up until now. His stools are normal prior to his melena with intermittent constipation. He has a history of a TIA for which he takes daily aspirin, and he drinks about 7 units of alcohol per week. So now you want to move on to your examination after you've got your full history. So we're moving on to our first question. So we've got a photo here of an abdomen with quite distended, dilated veins. So the question is, what is this? Is it telangiectasia, spider nevi, caput medusa, or ascites? So I'll give you some time to answer this question and we'll get back to the answers shortly. So for your examination, you want to start with your observation of the patient. Most importantly here, you want to check whether they have any stigmata of chronic liver disease. This includes quite a lot of different signs. Most commonly, patients get jaundiced. Have a look at their hands and look for any clubbing, palmar erythema, spider nevi. Look for Dupuytren's contracture. Look for gynecomastia, which is a sign in men of liver disease. Decreased body hair is another sign in both men and women. Look for testicular atrophy, caput medusa, ascites, so fluid in the abdomen, any splenomegaly and hepatomegaly, and any asterixes. You want to ask the patients to put their hands out in front of them and see if they have a liver flap. You want to assess the patient for any signs of anemia. So do they have conjunctival pallor or any angular stomatitis? And then check for evidence of encephalopathy. So this is basically decompensated liver disease, and it involves slowed mentation. So is the patient a bit disorientated and not quite with it? And do they have a liver flap, which is another term for asterixes? So make sure you check their hands and outstretched. You want to go on and do a full abdominal examination. So check for any epigastric tenderness or any masses, in particular epigastric masses, which could indicate a gastric tumour. Check for hepatosplenomegaly, which can indicate portal hypertension, which increases the risk of esophageal varices. Check for ascites, which is another sign of liver disease. And check for peritonism, so has the patient, is there an indication of perforation? And then you always want to do a digital rectal examination to assess for melena or any lower GI bleeding as well. So coming back to our question, so everyone's answered caput medusa, which is completely correct. So this is a sign of liver disease, and it's due to portal hypertension, and the veins around your abdomen get severely distended. So now we want to assess this patient with an upper GI bleed for his risk. So the first thing you want to do is distinguish between a varicose and a non-varicose bleed. So for your varicose assessment, this is a clinical assessment, and it assesses the likelihood of varices by establishing previous varices or any risk factors for liver disease or portal hypertension. So does he have a previous diagnosis of cirrhosis? Does he have any peripheral stigmata of chronic liver disease, as we mentioned? And do his bloods indicate liver disease? Or does he have any previous radiology or any current radiology that shows cirrhosis or any other liver disease? So once you've established whether there's a risk of varices, you want to go on to do the Glasgow-Blatchford score. So this is essentially a risk assessment tool which means that you can, if the patient has a low score, they are likely to be safe to be discharged and managed in an outpatient setting. If they have a high score, they'll need an endoscopy within 20 hours. And the Glasgow-Blatchford score includes quite simple measures. It's quite an easy and quick risk assessment tool to use. It includes blood urea, which, as we mentioned, indicates an upper GI bleed, hemoglobin, systolic blood pressure, and then a few other markers such as heart rate, whether there's any presence of melena, whether they've had syncope, previous hepatic disease, and previous cardiac failure. So back to our patient. We've resuscitated him successfully, and now we examine him fully. He's had epigastric tenderness, but no signs of peritonism or abdominal mass. He's had no stigmata of chronic liver disease, and a rectal examination revealed an enlarged prostate, and there was fresh melena on the glove, but there was no fresh rectal bleeding, so no bright red blood. His Glasgow-Blatchford score is 3, which gives him a predicted mortality of 11% and indicates urgent endoscopy for this man. So on to our next question. Let me activate it for you so you can answer. Bear with me. Okay, the next question is, the most common cause of upper GI bleeding is peptic ulcerization, esophageal varices, esophagitis, or Mallory-Weiss tear. So we'll carry on and we'll let you answer this, and we'll get back to the answer shortly. Okay, so what are the differentials for an upper GI bleed? Peptic ulceration, esophageal varices, bleeding gastric tumours, Mallory-Weiss tears, esophagitis, and vascular malformations are all the most common causes of upper GI bleeds. The most common cause in the UK is peptic ulcer disease. So this is about 26%, so about a quarter of patients presenting with upper GI bleeds have them due to peptic ulcers that are bleeding. Then we have gastric erosions or esophageal erosions causing 16%, esophagitis causes 17%, and varices causes 8%. So not a huge amount, of patients present with varices, but a very important differential to exclude. So peptic ulceration is the correct answer. About a quarter of patients present with peptic ulcer disease with an upper GI bleed. So what is your management of an upper GI bleed? So we've gone through the initial resuscitation. Then for ongoing management, you want to refer, especially our patient who presents with a high Glasgow-Blatchford score, you want to refer them for an urgent endoscopy. So this is endoscopy within 24 hours. So as an FY1, you want to prepare this patient for endoscopy. You won't be performing it yourself, but you want to make sure they're fit to go. So make sure you correct any clotting abnormalities. Very important to get a full clotting profile. You won't be expected to do this by yourself, but it's important to know what you can give to a patient with clotting abnormalities. Then you want to stop any offending medications. So we've mentioned some of the medications that increase your risk of upper GI bleeds, and that includes NSAIDs, aspirin, and steroids. So make sure you stop these drugs to not worsen the upper GI bleeding. You want to assess the anticoagulation. So do the seniors want to continue anticoagulating the patient whilst they're undergoing their endoscopy, or do you want to hold the anticoagulation? And then stop any antihypertensive if the patient is hemodynamically compromised. For endoscopy, you want to make sure the patient has fasted for at least 3 hours. The patient needs to be consented, and they need to have a cannula in situ and a valid group and save as well. And then make sure the patient has their case notes and all the observation charts ready to go down to the endoscopy unit. So how is the patient managed in endoscopy? So we split the management into non-varicose and varicose upper GI bleeds. For non-varicose upper GI bleeds, which mainly is peptic ulcer bleeds, but can be mallory rice tears and esophagitis, we usually use adrenaline injections in addition to another method. So that can be mechanical, for example, clips, which is commonly used. It can be thermal coagulation, which usually is diathermy, or hemospray, which is a topical mechanical hemostatic agent, as well as initiating and coagulating factors at the site of bleeding. For variceal bleeds, first line treatment is band ligation of the esophageal varices. And for gastric varices, usually is managed with thrombin injections. Sclerotherapy is sometimes also used, and if this is unsuccessful, we might insert a Sengstaken Blakemore tube, which is essentially a balloon that's blown up and compresses the site of bleeding to stop bleeding. For variceal bleeds, the patient is at higher risk of infection, so you want to give them prophylactic antibiotics. And if the above measures haven't worked, the patient goes on to have assessment for a TIPS, which is the transjugular intrahepatic portosystemic shunt. And this is essentially a shunt that is placed in between the portal vein and the hepatic vein, which allows fresh blood to go through the or to bypass the cirrhotic liver, and therefore lessening the pressure on the varices. So after the patient has undergone endoscopy, had its assessment for the cause of bleeding and then the management, you want to do the Rockall Score. So this assesses the patient's risk of rebleeding as well as the mortality risk for a patient after endoscopy. So the Rockall Score takes into account the patient's age, whether they've had any signs of shock, so if their blood pressure has been low, or they've had a heart rate or had a tachycardia. Do they have any comorbidities, in particular cardiac disease or renal disease? What is the diagnosis of the bleed? So a mallory rice tear has quite a low mortality risk, whereas malignancy has a high mortality risk. And what is the biopsy results as well? And the score of less than 3 gives you a mortality rate of 1%, whereas a score over 6 gives you a mortality rate of 15%, so quite a big difference. So our patient underwent urgent endoscopy and a bleeding duodenal ulcer was identified. This was successfully managed with adrenaline injections and diathermy. After endoscopy, he was prescribed H. pylori eradication therapy, and we're going to talk a bit about the causes of peptic ulcers and H. pylori. So on to the next question. So our next question is, what's the most common cause of peptic ulceration? Is it smoking, alcohol, NSAIDs, or H. pylori? So we'll come back to the answer in a bit. So let's just quickly go through the anatomy of the stomach. So the stomach starts at the end of the esophagus, and it's comprised of the cardia, the fundus, the body, and the pyloric antrum. Then under the body, you have the greater curvature and then the lesser curvature between the cardia and the antrum. It's supplied by the left gastric artery and right gastric artery superiorly, and then the left gastroepiploic artery and the right gastroepiploic artery inferiorly. We're going to briefly touch on the physiology just to improve your understanding of peptic ulcer disease. So we're going through it quite simply because there's quite a lot of complicated physiology to cover with the stomach. But essentially the stomach is lined by columnar epithelial cells, and these cells secrete a protective mucus that protects the epithelial layer from the acidic stomach environment. The parietal cells secrete hydrochloric acid via proton pumps, and this hydrochloric acid is important to digest the abdominal contents and also activates other cells such as pepsinogen. The megastrium, which is produced by G cells in the antrum, and this also stimulates acid secretion, whereas somatostatin, which is produced by D cells, suppresses acid secretion. So it's important to remember which cells secrete gastrin and which secrete somatostatin and what effect these have. Prostaglandins and peptides produce protective bicarbonate, and this bicarbonate is really important to try and tamper down the acid in the stomach so that the mucosal lining isn't damaged. So H. pylori is a bacteria, a gram-negative spiral flagellated bacteria that exists in about 50% of people over the age of 50 in the UK, has a much higher prevalence in non-developed countries, about 90%, and it's usually the cause of duodenal ulcers and about 70% in gastric ulcers. So the flagella on the H. pylori bacteria allows it to burrow into the mucosa of the stomach lining. And this means that it can go below the sort of acidic layer of the stomach and then live underneath the mucosa. And the way that H. pylori causes a peptic ulcer and inflammation is because it produces urease. And urease produces ammonia from the urea that's already present in the stomach contents, and this raises the pH of the stomach because ammonia is more basic than the acidic contents. So with this raised pH, the stomach lining is inflamed, especially in the antrum. So this antral inflammation causes a depletion of the D cells that we mentioned previously, and this means that less somatostatin is produced. Somatostatin inhibits acid production, so if there's less somatostatin, we get more acid production, and this increases inflammation in the stomach. And this inflammation eventually leads to ulcer formation. Now we're going to touch on why NSAIDs cause gastric ulcers. So this is NSAIDs most commonly cause gastric rather than duodenal ulcers. And the reason for this is because NSAIDs inhibit COX enzymes, and the COX enzyme produces prostaglandins, and prostaglandins is what helps produce bicarbonate, which reduces the pH and reduces the risk of inflammation. So when we inhibit the COX enzyme, we get a more acidic environment in the stomach, and therefore that causes inflammation of the gastric mucosa. So the most common cause of peptic ulceration is, as most of you rightly said, H. pylori. So this causes about 90% of duodenal ulcers, as mentioned, and 70% of gastric ulcers. So what are the clinical features of peptic ulcer disease? So patients often present with recurrent abdominal pain. This is the most common presentation. It's usually epigastric and it's often related to meals. So for gastric ulcers, they often present with pain shortly after meals, whereas in duodenal ulcers, it's usually 2 to 3 hours after meals. You might have heard patients say that they present with pain when they're hungry, but actually it's due to the emptying of the stomach contents, so about 2 to 3 hours after they've eaten. They might present with dyspepsia, so get any history of heartburn or any gastroesophageal reflux. And then get a history of bloating or belching, or whether they've felt excessively gassy. And then ask for hematemesis or melena and symptoms of anemia. So ask if they've experienced any dizziness, or if they've experienced any headaches or tachycardia or palpitations. Right, so we're on to our next and final question. In a patient with dyspepsia, which of the following is not regarded as an alarm feature? We're going to talk about what alarm features are shortly. Is it weight loss, dysphagia, no response to PPIs, iron deficiency anemia, or previous gastric ulcers? So alarm symptoms are any features alongside dyspepsia that are a cause for concern and indicate a need for urgent investigation. So essentially, patients with alarm symptoms have features of dyspepsia in addition to one of the following: bleeding or iron deficiency anemia, unexplained weight loss, progressive dysphagia, recurrent vomiting, previous peptic ulcers, a family history of gastrointestinal cancer, or if they're 55 years or older. So these patients need urgent investigation with endoscopy, and particularly for eradication or elimination of any gastric cancers. So you've had a patient presented with signs of gastric ulcers, maybe it might be epigastric pain. If they're presenting with alarm symptoms, as mentioned, they need to go for an urgent endoscopy. Otherwise, they will undergo H. pylori testing, as this is the most common cause. So this is commonly a carbon-13 urea breath test or a stool antigen test. H. pylori is managed quite simply. Sometimes it's managed without investigation with a trial of H. pylori eradication. And this includes a 7-day course of a PPI, so lansoprazole or omeprazole, in addition to 2 antibiotics. This is either amoxicillin and either clarithromycin or metronidazole. And in penicillin allergic patients, it will be clarithromycin and metronidazole. So patients are given a 7-day trial of H. pylori eradication, and if their symptoms haven't improved by then, they're referred for endoscopy. So in a patient with dyspepsia, which of the following is not regarded as an alarm feature? The correct answer is no response to PPIs. So weight loss, dysphagia, iron deficiency anemia, and previous gastric ulcers are all causes for concern, and the patient needs investigations for their dyspepsia. No response to PPIs is not an alarm feature and does not indicate urgent investigations. So that completes our lecture on peptic ulcer disease and upper GI bleeds. I hope that was informative. Please see the website Mind the Bleep for our other surgical series. They are run every Monday from 8 till 9. Apologies that this one was slightly late and we had some technical errors at the start. We would love your feedback, so please use this QR code to give us feedback, and if you have any questions, please don't hesitate to email us at webinars@mindthebleep.com. Thank you so much for watching. I'm going to leave this up on the screen for a little while longer.